Good afternoon, everyone, and welcome to the second call of the National Action Alliance Summer Webinar Series on addressing workplace violence. As you just heard, this call is being recorded for replay purposes. Both the recording and the slides being used today will be posted to the Action Alliance website after the call. Currently, all lines are muted. However, we would like for this to be an interactive session, and at different points in time, we'll be requesting to hear from you. You may chime in at any time using the chat function or when prompted by raising your hand. Thank you. Mr. Hatlie, the floor is yours.
Thank you, Jade. Hello, everybody. I'm Marty Hatlie. I'm the CEO and president of Project Patient Care. We're a small nonprofit organization that has worked for years to bring the voice of the patient and the lived experience of patients into improvement work. I'm also a founding member of a network that's affiliated with the World Health Organization called Patients for Patient Safety, and a leader in the US branch of this group. We're working as partners with policymakers and researchers and other passionate people about patient safety to make sure that it is a high priority for our country. So it's a great pleasure for me to be here working with you today, Jade, and our two fabulous speakers that you've recruited for this event. So without further ado, let me introduce those speakers. Cammie Chaumont Menendez has worked in the field of workplace violence at the National Institute of Health, National Institute for Occupational Safety and Health for 16 years. She's led many research projects on workplace violence, interventions designed to prevent workplace violence, and served on several National Academies of Science panels focused on workplace violence. So a very, very deep background in this topic. Safety and health equity are also important to Dr. Menendez, and she continues to be a leader in applying safety and health equity lens to every activity she undertakes as a scientist. Tyler Kerns is a licensed professional counselor and violence prevention and education consultant who has assisted Trinity Health System in developing and implementing its violence prevention systems. And Tyler, I think you're going to speak today, especially about St. Alphonsus' work here, St. Alphonsus in Boise, Idaho. I'll just say as an opening comment that one of the things that I've done in my career is to help hospitals and health systems start patient and family advisory councils that work on quality and safety issues. And I remember clear as day the first time when we were interviewing an applicant for a PFAC here in Chicago at a hospital, we had a person come on who asked whether this was 2012, whether the hospital had enough security to keep guns out of the hospital. And I was interviewing with the CMO of the hospital, and Tyler, it's now a Trinity hospital. It wasn't then. And we looked at each other just stunned at the question. Like, people are really worried about that kind of violence in hospitals. And now it doesn't feel like a strange thing to be worried about. It feels like it's almost a norm that we have to be aware of and protect against. So without further ado, I know we've got great presentations today, and I'm going to ask that we move to the next slide and welcome Dr. Menendez to make your presentation. Oh, goals for today. First, we're going to share what we know about violence in the workplace and how it manifests. There's going to be a lot of research that Dr. Menendez in particular will share with us. We'll identify some key strategies for addressing workplace violence. Those come from both Dr. Menendez and Tyler. And we'll hear about how these strategies are being implemented in different systems across the country. Okay, without further ado now, Cammie, please, the floor is yours.
Thank you so much, Marty. I really appreciate it. So I'm so grateful to be here with you all. And the topic of workplace violence, especially in this industry, is a sobering topic, but one in which we have tools and strategies that we know work. Next slide, please. So workplace violence is typically classified into 4 distinct categories. 2 of the categories are most frequently related to the healthcare industry, and that is type 2, customer or client. And in this industry, this means a patient. The perpetrator does have a valid purpose with the business or the establishment, but in the course of the worker performing their typical job duties, the patient or those with them, such as a family or associates, are involved in a violent incident. Now, type 3, that's your coworker perpetrated violence, and that includes a former coworker. In this type, the perpetrator has or had a labor arrangement with a business or establishment, such as current or former employment. The violence stems from interpersonal or work-related conflicts, losses, or traumas. Next slide, please. Now, we rely on the Bureau for Labor and Statistics to provide us with annual estimates of fatal and non-fatal injuries due to violence in the workplace. This figure uses incidence rates of non-fatal injuries involving days away from work per 10,000 full-time workers. So the highest rates within the healthcare and social assistance industry sector that result in days away from work come from the nursing and residential care facilities, which was consistently high for all years displayed, followed by those from hospitals, which were at their highest in 2020 for the years that I'm examining here. These data are publicly available from the tables cited below. Next slide. And then when we take a deeper dive into the hospital industry subsector, we see injury rates for psychiatric and substance misuse hospitals dominate, with some minor fluctuations over this time period, but exceedingly high rates are maintained compared to the rest of the hospital industry subsector. Next slide. And then when we look further into the other healthcare industry subsector, nursing and residential care facilities, we see the residential, intellectual and development disability, mental health, and substance misuse facilities alternate having the highest rates, with residential care facilities classified as other. Next, please. And still using publicly available data from the Bureau of Labor Statistics for non-fatal injuries due to violence from another person that resulted in days away from work, we see that all occupations overall had relatively low rates throughout the time period studied. Of course, we'd like for them to be zero, but they were relatively low rates. However, as we start to go down the list of occupations that I picked out that serve the healthcare industry, we find that, next slide, psychiatric technicians and psychiatric aides have tremendously high rates of days away from work due to injuries sustained on the job. Next slide. And then nursing occupations, and this is along with EMTs and paramedics, had high rates that were their highest in 2020 for the time period studied. Presented here are the affected nursing occupations, registered nurses, kind of on the bottom there, licensed practical and vocational nurses, and then nursing assistants, who had the highest rates of workplace violence that also climbed to the highest rate for 2020 for the time period studied. Next slide. The Bureau of Labor Statistics last provided a breakdown of incidence rates by race and ethnicity in 2018, and here are incidence rates for days away from work for all private industry overall, and then moving to the right, the healthcare and social assistance industry sector, and then each of the 4 subsectors within the healthcare industry. This figure is not specific to violence, I couldn't get that data, and includes all non-fatal injuries such as slips, trips, and falls, and those from overexertion. But we do see differences by race and ethnicity. Specifically within the healthcare industry sectors, we see workers who are Black consistently have the highest injury rates, with the exception of nursing care facilities, where they are then the second highest, while workers who are Hispanic and those who are Native Hawaiian or Pacific Islander also having consistently high incidence rates. Next slide. Last summer, NIOSH, the institute where I work, in partnership with the Department of Justice and the Bureau of Labor Statistics, released a document available online detailing 13 indicators of workplace violence spanning the years 2015 through 2019. Here we see from 1992 to 2019, 17,865 workers were victims of workplace homicides. In 2019, 454 homicides occurred, which was down almost 60% from a peak of 1,080 in 1994. There were 392 homicides in 2020, for perspective. From 2015 to 2019, sales-related occupations, and those are your, think convenience store workers, they averaged about 96 homicides per year, and then protective service occupations, these are law enforcement officers, averaged 86 homicides, the highest of all occupations. Healthcare support occupations averaged 6 homicides per year, among the lowest of all of the occupations. Now, to learn more about work-related homicides in the U.S., I encourage you to download the report available at the website listed in the footnote, or please reach out to me if you have any problems finding it. Next slide. Our colleagues at the Research Division within the Joint Commission published a summary of healthcare worker violent deaths occurring in the workplace spanning 2003 through 2016 and found 21 healthcare workers died from a homicide. Of these homicides, there were too few to report among the physicians or nursing staff who died in this manner. The remainder of the homicides were distributed equally among therapists and technicians, those in security and environmental services, and administration and support operations. 7 of the homicides were type 2, where the perpetrator is a patient, family member, or visitor. And then 7 were type 4, where the perpetrator has a personal relationship to the employee outside of the workplace. What is noteworthy about this analysis, additionally, is that there were more suicides at 32 over this time span than there were homicides. It is important to promote mental health and well-being efforts in the healthcare industry, in addition to those focused on preventing workplace violence. Next slide, please. So let's focus on type 2, or patient-based workplace violence. This quote that I just had you read is attributed to Patty Coons-Howard, president of the Emergency Nurses Association, and this was said in 2019 before the pandemic. Next slide, please. The risk factors for patients who may perpetrate violence can be categorized into clinical, environmental, organizational, and socioeconomic. Clinical risk factors include patients who are under the influence of drugs or alcohol, those who are in pain, those who have a history of violence, and still there are other reasons. Next slide. Environmental risk factors are related to the layout, design, and amenities of the physical workspace. So these include opportunities to gain access or avoid detection, such as unmonitored entries or stairwells or insufficient lighting. Also, risk factors that increase stress on visitors or patients, such as confusing signage or disturbing noise levels. And amenities that provide opportunities to be used as weapons, such as unsecured furniture, fixtures, or supplies. Or more risk factors are a lack of alarms or other means of emergency communication that limit staff's ability to appropriately respond to violent incidents. The layout might also interfere with escape or seeking help when needed. Next slide. Organizational risk factors include complacent attitudes towards workplace violence prevention, inadequate security procedures and protocols, and a lack of staff training and preparedness. Are reporting policies cumbersome, and is the crisis management approach adequate? Working extended shifts or under low staffing levels are also risk factors for workplace violence. Next slide. Social and economic risk factors are those that are present in the community serving a healthcare institution and can contribute to creating a climate in which violence is encouraged or tolerated. These can be high concentrations of poverty, diminished economic opportunities, high levels of family disruption, low community participation, and neighborhoods that are socially disorganized. There are health, educational, and social policies that help to maintain economic or social inequalities between groups in society. These all create strains on healthcare systems and the patients that use the healthcare systems, and the workforce serving the healthcare systems, and at times when more people are seeking healthcare services, and any or all of these can set the stage for violence. Next slide, please. So let's discuss some studies that I had found. A study published in 2021 in the American Journal of Emergency Medicine compared the experiences of healthcare workers in an emergency department in April of 2020 with December of 2020 in the Midwestern US, using surveys and electronic medical record reviews. The authors found, in line with an increase in COVID cases over this time period, there was double the rate of workplace violence that included both physical assaults and verbal assaults where security were called to respond. The authors found there was no significant increase in prevalence over the 8-month period in verbal abuse, which I have to say was already very high, but there was a significant increase in frequency of verbal abuse occurring every day or two versus monthly or less than each month. Regarding physical assaults, there was an increase in being assaulted with bodily fluids, and this was experienced primarily by nursing staff, but no significant increase in assault with weapons or physical attacks. Next slide, please. Then there was a separate study published in 2022 in Workplace Health and Safety that reported on hospital nurses in the US completing an online survey between February and May or June of 2020. Almost 68% of the nurses reported experiencing verbal abuse during this time frame. Nurses who provided care for COVID patients were twice as likely to experience verbal abuse than those not caring for COVID patients. Regarding physical assaults, just under half of nurses, at 44%, reported physical assaults during this time frame. Again, nurses caring for COVID patients were twice as likely to be physically assaulted than those not caring for them. And approximately 9% of nurses, or about 1 in 10, felt reporting incidents to management was more difficult during the pandemic. Next slide. Much of the workplace violence research and advocacy I encountered in my searches, and that continued into the pandemic, was the consistent mention of type 3 violence with type 2 in the nursing professions. So type 3 violence research, and that again is of coworker on coworker, and coworker includes your supervisor, is not as frequently studied as client or customer-based research, but in working populations, it can also result in injury and death. In healthcare settings, it serves to undermine patient safety and health. According to the Joint Commission, the accrediting agency for healthcare facilities, root causes and contributing factors are individual and systemic. In workplaces with a high-stress environment, coupled with emotional work and long work hours and/or shift work where fatigue can often be present, there is an opportunity for intimidating or disrupting behavior to occur among the workforce. Furthermore, individuals lacking in interpersonal, coping, or conflict management skills may contribute to already challenging environments by making them intimidating or disruptive for coworkers. Additionally, there are systemic factors found in the healthcare environment: productivity demands, cost containment requirements, there are embedded hierarchies, concerns about potential litigation, changing or different professional roles or values, and power differentials among staff, and staff and shift scheduling that all contribute to a dynamic for suboptimal team functioning. Next slide, please. So in an online survey conducted June to September of 2020 with nurses responding, 37% experienced more incivility than before the pandemic. And 42% said their incivility was perpetrated by nurses, but then almost as much, 41% of the incivility was perpetrated by supervisors. 46% reported that they witnessed more incivility than before the pandemic, and then 26% experienced cyber incivility more than before the pandemic. So 23% of the cyber incivility was perpetrated by nurses, and roughly half of this was perpetrated by supervisors. Next slide, please. So this concludes part 1 of the presentation.
Great, thank you, Cammie. This is just incredible data that you're sharing with us, and lots of insights. We have our first question for all of us to run on, and what are the 2 types of workplace violence prevalent in the healthcare industry? So what did you all hear from the first part of Cammie's presentation? You can just enter your answer into the chat function. We'll give you about 30 seconds to do that before we move on to part 2. Okay.
It may just be me, but I can't enter into the chat function. Is that because I'm a panelist? It's great.
You should be able, everyone should be able to enter into the chat.
Tyler's testing it for us. Tyler can do it.
Thank
Okay.
you, Tyler. Okay. Yeah, I'm not certain, but in any case, we will move on to part 2. Cammie, thank you. Next slide.
Thank you. So in 2016, OSHA updated their 1996 and 2004 voluntary guidelines for workplace violence prevention programs for healthcare and social service workers. So this update recognizes 5 different settings in which these professionals work in an effort to reach the broad spectrum of workers in this industry: hospital, residential and non-residential treatment, community care, and field work. These are your home healthcare workers. Management commitment and worker involvement for this industry means promoting the value of a safe and healthful workplace with equal commitment to the safety and health of workers and patients or clients. All are needed and everyone has a role to play. Worksite analysis involves analyzing the workplace security and other violence prevention measures in place. So going through past records of incidents is advisable, but also being mindful of workplace violence that has occurred but was not reported and documented. This is where risk factors such as a history of violence in a patient is crucial to understand and be documented. And hazard prevention and control measures applied in this industry could include substituting a safer work practice, which can be challenging. An example may be transferring a patient with a history of violent behavior to a more appropriate facility. Engineering controls include the use of physical barriers or door locks to protect employees, metal detectors for where it makes sense, or better lighting. These are implemented depending on the setting. For field worker, engineering controls would include GPS tracking for security or cell phones for raising an alarm. Administrative controls would include tracking workers and tracking clients with a known history of violence, entry procedures, and then administering employee uniforms, for example. Annual safety and health training should be accessible to all staff, whether management or frontline worker, whether temporary or contractor or permanent, really, truly everyone in your facility, on recognizing and mitigating violence, seeking care if injured, and evaluating the training then periodically. Training should be offered in a format and a comprehension level that meets all of the staff's needs. So for a decade now, NIOSH has offered free online training in workplace violence prevention for nurses that is actually relevant to all members of a healthcare team. Workplace violence training that includes conflict resolution, emotional intelligence, and other interpersonal skills is also advantageous. The importance of record keeping cannot be overstated. And to fully understand and effectively communicate the burden of workplace violence in an establishment, to assess hazard mitigation approaches and identify training needs record-keeping practices that are consistent and complete. The ability to assess trends leads to identifying improvements needed for the violence prevention program. This is why the findings of the previous study reported on in part 1 that found that 1 in 10 nurses found it more challenging to report their incident are so important. Already there are too many incidents that go unreported, and we don't need any more barriers to reporting. Checklists used to assess workplace violence prevention program for this industry was adapted from that of the California Department of Human Resources, and it's available at the link below. This entire document is. Next slide. Now, the state of California promulgated a violence prevention in healthcare standard in 2016 that's cited below. The standard mandates the establishment, implementation, and maintenance of an effective workplace violence prevention program. And then it goes on to describe the elements required to meet each of these action items and provides special considerations in identifying procedures to addressing safety by type of workplace. It also goes on to provide engineering and work practice controls to correct workplace violence hazards, input into a violence incident log, reporting requirements within 24 hours of a fatality or hospitalized injury, and then within 72 hours otherwise, and a new employee, new workplace hazard and refresher training requirement, and record-keeping requirements. So the standard echoes recommendations made by OSHA for the healthcare industry, and this standard requires participation by workers. And again, the link is below on this slide. Next slide. Now, effective January 1st of last year, 2022, the Joint Commission issued 5 new and revised workplace violence prevention standards. They are mandated for all Joint Commission accredited hospitals and critical access hospitals. In order to develop these standards, there was an extensive literature review and public field review, the establishment of a technical advisory panel, and a standards review panel. So the standards relate to the environment of care. That is, it manages safety and security risks and collects information to monitor these conditions. The standards also relate to human resources, that there is education and training for staff, and it also relates to leadership through the creation and maintenance of a safety and quality of culture. The standards can be accessed in the link below. Next slide. Again, here's a slide on the NIOSH training that we've provided for about a decade. And again, it's relevant to all members of a healthcare team. There are 13 units or modules that take approximately 15 minutes each to complete with a knowledge quiz included for practice. The course covers identifying workplace violence, risk factors for both patient-based or client-based violence, as well as coworker-based, and prevention strategies at the organizational level, at the nurse level, and then intervention strategies such as de-escalation and crisis management. Then each of 5 case studies presented by video-based scenarios based on real-life incidents are their own units. At the end, there is opportunity for healthcare professionals, including health educators, to apply for CE credits and take a test and course evaluation. Next slide. From 2013 to 2015, NIOSH surveyed participants registered for the course, and of almost 15,000 participants, 85% were nurses, and about 2/3 worked directly with patients. 94% had experienced verbal workplace violence in the past 12 months, and almost 20% had experienced physical workplace violence. 96% of those surveyed felt that the course was a good introduction to workplace violence and met the learning objectives. 95% felt they could identify workplace risk factors, recognize the behavioral warning signs, employ communication and teamwork skills to prevent and manage violence, and identify appropriate resources to support injured nurses. 90% felt they could take steps to implement a comprehensive violence prevention program in their workplace. So please consider taking this free online course at your convenience to further reinforce the safety trainings you have taken. Next slide. I'd also like to highlight some recent research evaluating workplace violence prevention strategies. In 2022, the World Views on Evidence-Based Nursing published a pre-post evaluation of a Behavioral Emergency Response Team, or BERT, program designed in-house, and it was implemented to help healthcare teams identify and de-escalate potentially violent and aggressive patient behaviors. Nurses, nursing assistants, telecommunication dispatchers, and BERT responders participated in the study. So key findings were bedside nursing program participants felt more confident and capable of managing aggressive patient behaviors. Security officers and nursing staff formed a strong partnership that identified potentially aggressive patients and intervened to improve clinical practice safety. Formal reports of patient aggression episodes did not increase during this study. Next slide, please. In 2017, the Journal of Occupational Environmental Medicine published a randomized controlled trial in a hospital setting evaluating the effectiveness of unit-specific violence prevention action plans. Unit-level violence data informed the action plans for the units randomly assigned to the intervention study group. Key findings were, at 6 months post-intervention, there were fewer violent events in the intervention group, and then at 24 months later, there were fewer injuries due to violence. Next slide. This year, the Journal of Nursing Administration published a study evaluating the effectiveness of a supplemental patient violence assessment tool used in Canada across patient care settings with violence prevention efforts that were already in place. This was meant to be supplemental. The intervention consisted of the assessment tool, communication with patients, and then enhanced safety practices consistent with recommendations in OSHA's Workplace Violence Prevention Program for those with high scores using the assessment tool. Pre-post measures of the assessment tool and injuries were examined. And key findings for this study were reporting of employee injury increased, which was expected, and a majority of the units observed the same or improved rates of employee-reported injuries. This was considered an encouraging finding given the increased frequency of violence towards healthcare workers during the pandemic. Next slide. Thank you so very much for your time, and I am happy to provide you with references included in this presentation by email if you have any problems accessing them. I'd like to acknowledge the assistance of Emily Austin for a more visually appealing presentation, and Jane Thomason from National Nurses United and Barbara Brown from the Joint Commission for sharing their expertise.
That was great. Thank you so much, Cammie. Can we have the next slide, please? We'd like to take this opportunity. We're going to try our very best with the technology that we have to debrief from all of the great information that Cammie's provided. So we'd like to hear from you and what your number one takeaway is from the presentation, and then how does that track with your own observations or experiences. And the way that we can do this, I'm hoping that at least some of you are able to enter your responses into the chat. But also, if you would like to answer the question with your voice, raise your hand and we will unmute you so that we can hear your response.
Jade, my chat is working now, so I think we've solved that problem.
Yay.
Go team.
I know, technology. And please feel free to enter your response into the chat so that we can capture that for the call. I'm not seeing anyone with their...
If I may.
Please.
I think we're officially post-pandemic now. Anything in the data about how things might have improved or gotten worse post-pandemic versus the crisis we were all in during the pandemic.
Great, thank you, Marty. I think you were breaking up just a tad, but I think what you were saying is that go ahead. You're not frozen now.
Oh, okay. I was just wondering if when we might see data post-pandemic to see if things have improved after the pandemic has lessened or is officially over now. When do you expect to see that? Or is there some already that you're seeing? Cammie, can you hear me?
Yes, I can hear you. Unfortunately, the data that I presented were the most recent that we have available to us. So I really rely on, we rely on studies to be conducted and published in real time. I know at CDC, a bunch of us researchers were able to get special funding to kind of conduct studies during the emergency phase so that we can try and collect data and get information out there as soon as possible. And we haven't been able, in general, folks who are collecting data, both in research and also with the federal government, we don't have information available just yet about violence trends that are coming down, and I'm monitoring those and looking to see with the immense and national level databases that we have, like the data that I presented earlier. That's all publicly available, and it's the Bureau of Labor Statistics, and they do such an amazing job. You can imagine it takes some time to get that data out. And also I look for studies from academicians and other folks in the healthcare industry that focus on this topic. And I would hope that maybe even, currently, like in the next few months and at the end of the year and next year, we'll start to see data that's published so we can really start to see things that are coming down. In one of the studies that I reference in part 1, I didn't show the figure because there was a time constraint, but they had in the early stages of the pandemic, they did have as the regional referral hospital rates went up, that's when you could see it was tracked. They had their highest violence incident rate, and then it declined as soon as the COVID rates went down. So that is one example of something that I think was published last year, and you could see it for that region. It was really interesting how the figure was tracked, and it's cited in the presentation. I'd be happy to share that with you. But that's, I think, the most compelling that I've seen thus far.
And encouraging.
Yeah, thank you, Cammie. That is very encouraging. And no doubt the pandemic has exacerbated everything that you can imagine, particularly in the healthcare setting. So I did not see anyone who had raised their hands and not seen anything in the chat. So let's move on, because now we would like to hear from Tyler Kerns. And Tyler's going to share with us some of his strategies around implementation. So Tyler.
Thank you. My name's Tyler Kerns. I'm a licensed professional counselor. I function as the violence prevention and education consultant for St. Alphonsus Health System here in Southwest Idaho and Eastern Oregon. And I'm also currently functioning as the national chairperson for Trinity Health's Violence Prevention Steering Committee. Wanted to take some opportunity to share with you some best practices and implementation strategy for really improving and addressing this growing issue within our industry. Next slide. As Cammie clearly showed us, the frequency of violence and aggression towards healthcare workers is increasing across the country. And with this evolving threat, it requires a progressive approach for managing and improving healthcare worker safety. This really requires more than just what we've traditionally thought of as a security role and capacity. It takes commitment from leadership throughout the organization. It takes interdisciplinary expertise, and it takes resources and time. Thinking of this as a cost is not really the perspective that we need to take. This is an investment in the safety and well-being of our employees. Trinity Health has taken this on, and some of our approaches, we've incorporated safety as one of our organizational core values in 2020. We really view colleague safety and patient safety as one. These are fully integrated, and our strategies and teams collaborate to make sure that they support and bolster one another. We've included our OSHA injury and events as our board of director goals for each of our regional ministries since 2021, ensuring that stakeholders at every level within the organization are prioritizing employee safety. And this past fiscal year, we've seen nearly 400 fewer OSHA recordable injuries across the board, enterprise-wide. We've built into our leadership and strategy a 5-team colleague safety strategy. We are looking at various safety risks on the job. One of them, and my focal point being workplace violence. Next slide. Some of the components that we've really been looking at, it echoes what Cammie shared. When we first took a look at this, Trinity Health is a very large health system across the country. We serve a variety of patient populations and have facilities, inpatient, ambulatory, long-term care, assisted living. And we wanted to look at what we could do to help bring all of those areas in line and standardize our approach. And really the first step was creating a steering committee to look at what are some of the best practices being utilized throughout our organization by some of our ministries that are leading this work, and best practices that are being done in other outside health systems. In looking at all of those, we've pulled together and created a guidebook that we use to outline specific details on how to implement and sustain utilization of those best practices that we've made available to all of our ministry sites, that functions really as a roadmap for getting to all of those best practices that Cammie had referenced. One of the big initiatives that we've just worked on, and again, being able to look at and identify where we're having issues or risk to our employees, we've integrated the BROSET violence checklist into our electronic medical record. We've done this across all of our regional ministries that are currently using Epic. This has become a standard workflow item to where we identify patients that may be at a greater risk of violence in the next 24 hours. We're doing this during triage and intake, both in the emergency department and the acute setting. So if we have an interdisciplinary interagency transfer, we're screening them at this point as well. This allows us to identify where those patients that may pose a greater risk to our staff may be. And in part of that integration of the screening tool, we've built into the EMR a cascading list of safety interventions based on the acuity of the score. So we're not only identifying where there might be an increase in risk, we're also building into the process preemptive strategies to help mitigate there being an incident. As discussed earlier, reporting has really been a big issue. I can speak to my experience both as frontline staff and now moving into leadership, helping to improve our response to workplace violence. And one of the approaches that we've taken on is providing a real-time response to workplace violence, in addition to other types of workplace injuries. We've calling this a code safety or a swarm. It provides more than just a security response. It gets security, it gets leadership, and it gets clinical support so that the colleague has security to mitigate the ongoing threat. We have leadership there to look at what happened, what led up to it. More importantly, as an organization, what can we do to help prevent it? And we have that clinical leadership. Typically, our clinical coordinators or house supervisors of care they make if an injury was sustained. And then we aid them in documenting the event, right? Having quality response in real time to that incident of workplace violence improves reporting. It improves that employee engagement so they feel like their safety truly matters. The education component, as discussed with the new Joint Commission accreditation requirements, this was a major component of that new accreditation piece. We have taken upon ourselves to standardize our violence prevention de-escalation training for all of our security members across Trinity Health. We're using the same curriculums so that we have consistency, emphasizing on DEI, and improving patient-client visitor interactions, making sure that in recent years, law enforcement and security individuals have been certainly under the microscope, and rightfully so, to ensure that any interaction with patients or our clients is held to the highest standard of accountability. With that, we are also looking at creating a 3-tiered proprietary curriculum that we plan to use as a standard education tool across all of Trinity Health. Taking that 3-tiered approach, we would look at our data tracking, and I'll discuss that a bit more here in a moment, but looking at exposure, risk to violence, specific areas of the hospital, certain departments, certain job roles, and being able to identify where we're seeing the greatest exposure to violence and aggression, and getting those colleagues the proportionate training to help best prepare them and keep them safe in their workflow. As far as data tracking, really, in order to have a good understanding of what's going on within your organization, your understanding is really only as good as the data, which is really only as good as the reporting. By implementing that code safety real-time response, we've seen an uptick in reporting from our colleagues on the front line. And with that increase in reporting of events, not just OSHA recordable injuries, but any injury or any event, even if injury doesn't occur, attempted physical violence, verbal threats of harm, we've taught to this to include all of these capacities of violence in the reporting process. And with that increase in reporting, we're getting much better understanding of where we're having issues and the degree. We've built data tracking approaches, dashboards at a number of our ministries that we've piloted. We are in the process of expanding this to make it a standard use at all of our regional ministries. This will allow us to better stratify and analyze the data by date, by location, unit, the type of incident, the severity, including all the way down to the job role of the colleague that was impacted by the event. We're using these ministry-specific down to the colleague-specific dashboards in conjunction with our existing Trinity Health workplace violence dashboards to gain a better understanding of where we're at and to give better visibility to our leadership so that it improves that connection between those who are leading the organizations and those who are on the front line caring for our patients, so we can better understand the needs to keep those colleagues safe. At each of our ministry locations, we have established workplace violence prevention steering committees on the local level. Within that guidebook, we've outlined for each of our ministries how to set up those steering committees, how to facilitate and bolster their programs, taking all of those best practices. And this local ownership and accountability really improves the prevention. They're going to know their hospitals best rather than having an outside, larger group telling them how to best manage it. But looking at these components, taking more of a holistic approach, want to look at additional best practices here that we're considering and currently working on. Next slide, if you would. Use of behavioral emergency response teams. We have a number of ministries currently utilizing this strategy. This provides the ability for getting clinical mental health expertise to the front lines, to our nursing areas that maybe don't have that same degree of experience. We're utilizing the Broset violence checklist, identifying those patients that have a higher acuity for violence, and using that for a caseload to where our BERT teams are rounding on those patients, getting the best resources to the areas that we're seeing the most potential for violence and aggression. We've included signage that we've standardized a message that we're posting to the public, a message that violence will not be tolerated, outlining specific behaviors that would fall under that inappropriate behavior, and sending the message that this is a priority, that we are here within this healing environment, and that includes our colleagues as well. We're actively working on crafting a patient code of conduct. We're modeling this after a number of other major health systems across the country that have already implemented this and set precedent to clearly outline what the expectations that patient can expect from us as their care provider and what we expect in return as interaction with our colleagues. We're considering standardization approaches for use of metal detectors. We're looking at best practices across our enterprise where they are actively being utilized and looking at ways to expand. Our canine programs are being utilized in a number of different sites, both in the capacity for weapons detection, but the primary use in our local ministry, I can give you the example, our securities canine is a service dog, is used primarily in de-escalation. And really diving in as a leader in the industry, looking at gun violence prevention initiatives, training, and advocacy, right? Trinity Health regularly puts out advocacy initiatives to all of our colleagues to look at what is it that we are doing and where can we speak up to make a difference on the national level on the legislation front. Next slide. Looking at implementation, a major piece of this in getting the right folks at the table for your program is identifying the right stakeholders. This needs to be an interdisciplinary approach. It needs to include risk, security, senior leadership, patient safety, colleague safety, physical security, engineering, the layout of the organization, but also frontline colleagues. Our frontline staff are going to know where these risks are lying and leveraging that expertise from all layers of the organization. Once you've identified your stakeholders of who needs to be involved in the creation and bolstering of your violence prevention initiatives, you need to have an identified leader. This is not an add-on responsibility or additional duties as assigned. This should be a core responsibility. Safety is not a second thought. This needs to be a primary focus of this individual taking on leadership and accountability for your program. In scaling your engagement, helping to foster normalizing discussion of workplace violence within your organization, right? We need to be talking about workplace violence incidents during our daily safety huddles, during shift change. We have weekly reviews of incidents on the local level, including our workplace violence prevention stakeholders and senior leadership. We have monthly meetings to review events and look at trends, and we report out quarterly to our boards for that accountability component. And then having annual reviews of your program to see where you've moved the needle and where there's additional opportunity for growth. The accreditation component, healthcare systems, we talk a lot about the Joint Commission and CMS, and we have to consider that, but not everyone falls under the Joint Commission for their accreditation. So it's important that you and your stakeholders are aware of what local, state, or federal accreditation and regulation requirements may be applicable to your organization and when changes occur. And look at not just meeting those, but exceeding them. Look for opportunities where best practices are being utilized in other organizations. Learn from where others have stood. Take the opportunity to see where you can apply that into your own organization. And I'd say probably the biggest aspect of this to getting a successful program going is shifting culture. I can't tell you how many times over my career I've heard a nurse or a CNA say, well, it's the ER. What do you expect? Or we work behavioral health. It's part of the job. we need to communicate as leaders that this is not part of the job, that workplace violence may be occurring in healthcare, but it is not a part of healthcare, right? Discuss this, integrate it into the fabric of your organization, and really empower colleagues to speak up when something doesn't feel safe. Streamline that reporting process, give them support, and demonstrate from the organizational level that you are taking actions to address it. Get this out into the colleague realm, into their visibility. Make sure that they're aware not only that we're doing work, but let them see where it's occurring. Follow up and take their feedback and help utilize their input in developing these approaches. Next slide. Looking at the impact Trinity Health nationwide, since we've invested in workplace safety in our workforce, it's yielded support from our frontline staff. We've seen improvement in colleague engagement. We've seen a decrease, 37.7%, in our workers' compensation tied to workplace violence. We've seen a drop in our lost days and our DART rate. And really all of this comes from having that big picture perspective to where we're looking at this from all angles, that it's not just a security responsibility. This is going to take all of us to really put that first step forward to make the difference for our frontline staff. So I want to go ahead and turn it back over to Jade, if you would like, or to, pardon me, to Marty, and we can field any questions. I saw a lot going on in the chat, but I wasn't able to keep up with all of that.
Yeah, the floodgates have opened now that the chat function is working, and we're so grateful for it. Lots of great questions. Tyler, I've seen several requests for any of the tools that you are using, including there was one for signage. And if you are okay with that, we were happy to post anything that you would like on the Action Alliance website. I will note that both the slides and the verbal replay will be available probably later this week, if not earlier next week, from this call. So you'll be able to share the information. I'm just reading. Go ahead, Marty.
I've got a question. There's a does any of the data that we've looked at today include patient on patient or patient on visitor violence events? Because I hear anecdotal reports about it. I don't know if it's going up or down. Cammie, I don't know if that's a question for you or Tyler.
I can speak to my assessment of data here on the local level and speaking with other ministries within Trinity. The vast majority of our workplace violence that we're experiencing is type 2 and type 3. Very occasionally, I would say outliers. I have seen examples of patient towards another patient or patient towards a visitor, non-employed person there within the facility, but that is far and away a rarity when compared to the other types of violence we're experiencing.
Tyler, I have another follow-up for you. When violence happens, when the events happen, what kind of trauma support is St. Alphonsus or Trinity as a system mobilizing to take care of people who've experienced this?
That's an excellent question, Marty. As part of that code safety response, when we have security, leadership, and clinical support to that colleague after the incident, part of the debrief process includes connecting them with employee assistance programs, getting them with the resources if they need to follow up with one of our EAP counselors, letting them know how to do that, walking them through the process if need be. We also have various other approaches that we're using, critical incident stress management for more significant events, not just workplace violence, but if there's a bad code or a major significant event, mass casualty event in the community. We are exploring additional approaches beyond just the traditional EAP for making sure that our colleagues are getting the support they need so they can continue to do the work they do for the long term.
Yes. Thank you, Tyler.
And I would like to add that the NIOSH online training, also we have a module on crisis management, and we do cover that topic as well.
Yeah. I mean, one of the things that I know AHRQ has developed and that I've been part of is the Candor program, and there's a lot of peer support there. This is really not focused on workplace violence, focused on the kind of trauma that healthcare workers experience if they've made a mistake that's harmed a patient. But a thing that's working there is peer-to-peer support, just, you know, nurses getting together or other colleagues getting together to just mobilize and take care of somebody who's had a bad event. It's just been beautiful to see that happen as part of the culture change shift in the organizations that I've seen adopt it.
That's a great
Anyway.
comment, Marty. On that kind of that same subject, if I could have the next slide, please. AHRQ also has the surveys on patient safety culture. If this is something that you're not using, you might consider it. These are validated surveys that assess patient safety culture across different healthcare settings. And the team has developed some supplemental item sets that are geared toward workplace safety to accompany the hospital safety of culture survey and the nursing home safety of culture survey. And you can see here they include these domains: workplace aggression policies, workplace stress, burnout, interactions amongst staff, of course, related to nursing homes. Also, the SOPS program provides private feedback reports for those facilities that choose to submit data to the database, and there is some technical assistance available. So I think it's, you know, just important to note that while many of us, many of the frontline staff are experiencing this, there are some tools and resources available. And then of course we've heard from Tyler, who has made some really incredible inroads into how St. Alphonsus and Trinity Health are handling violence in the workplace. Next slide, please. First of all, I just wanted to say thank you to all of our speakers today, and thanks to each and every one of you who took time out of your very busy day to join us for this important topic. We are so grateful to you for the work that you do on behalf of patients, and we hope that you will join us for the next National Action Alliance Summer Webinar, which is going to be held on July 25th from 2 to 3 p.m. Eastern. And the title of that will be Involving Patients and Families in Safety. Registration is open for that and can also be found on the National Action Alliance website. With that said, we would like to thank you for joining the call today, and we will adjourn.
Thank you.
Thank you.
Thank you. Thank you, everyone. Wonderful job.
Yeah, very nice job.
That was wonderful. I'm so